Thank you everyone for joining today for the fourth Stop COVID webinar. So my name is Stacey Todd and I am the LHP Programme Director for Infection, and William Hope has asked if I will chair today. So I'm just going to give a very brief update on where we are just now, and then we've got four lovely speakers today who are going to be talking about giving us some updates on the projects that have been running. We've got Professor Callum Semple, who's going to be talking to us about the ISARIC study, which has been one of the largest UPH badge studies that we've been recruiting for in the UK. We've got Carlo Palmieri talking about the CCP Cancer Project, which is an add-on to the ISARIC protocol, and talking very much about the impact of COVID in our cancer patients. And finally, we've got the team speaking about Pippa and Mark talking to us about COVID and social science and how that's impacting things. So just a couple of quick housekeeping rules, just to remind everyone that this is webinars being recorded, and it will be available to view on the LHP website. Please share the links for this and all the previous webinars with your friends, your colleagues, your mums, your dads, your dogs. We want everyone to know what's going on and all the wonderful work that everyone's been doing. And just as another reminder to say that we can questions and answers will be having towards the end for 15 minutes with the whole panel. If you can please put your Q&As in the Q&A box, that would be great. And we can have a chat and discussions towards the end, and that'll be fine. So I don't have any particular slides today, but what I wanted to chat about was actually just to give a bit of an update on where we are with COVID. So I'm an infectious diseases physician based at the Royal and sort of working across both sites of sort of Royal and Aintree. So we are sort of taking the bulk of the COVID admissions within the city, and sadly, as I'm sure many of you will have seen in the press, Liverpool's numbers are going through the roof over the last few weeks. We're up to over sort of 200 cases per 100,000 in the city at the moment. We are starting to see that translated into cases within the hospital. So over the last week, we've had a massive surge in inpatients with COVID, sort of here at the hospital. So we're back, while we're not back to where we were in April time, we're certainly seeing a significant number of readmissions. Things are different, and I think actually it's testament to many of the people who are on this call and so many of you who will have joined, that actually we are in a much different position to where we were when we were with similar numbers back in March. We have a much better understanding of this disease. We have better understandings about how to prognosticate from Callum's work in the team at ISARIC. We've also got treatments that we didn't have before, and it's been wonderful sort of through Stop COVID and the work that we've done that we're now able to offer dexamethasone, sort of understanding through the recovery trial, and we've got remdesivir here at the Royal. But this hasn't stopped our need for research and to understand this disease. So what I wanted just very briefly to touch on in my Stop COVID update is to talk a little bit about what the research delivery teams have been doing for this, and the numbers of people that have actually been involved in this COVID response. It's great on these webinars that we hear from the research leaders who are really got sort of instigating, thinking about all of these great studies, but all of this work can't be done without our amazingly dedicated sort of research delivery teams that are working across the city, in hospitals and primary care, in the universities and the HEIs. So here at Luft, we've really pooled all of our research resources, and all of our research nurses have been coming together over the last few months to work intensively on these research and on the COVID research. We were increasingly going back to non-COVID research, but we've had, with the increasing numbers, we're flexing back to really focusing on delivering our COVID research objectives. We're trying hard we've got the CMO mandated target of 60% recruitment into the recovery trial. So drug trials for for COVID, and that's been going really well. And I think actually it's been the increasing recognition of the value of the research that we're doing and the practical nature of it, that it's really focused on bringing us answers. As clinicians, we're looking for answers to help us look after our patients. And that's really made a massive difference for us. So we're seeing more and more of our trainees are interested in this. They're wanting to take part in this. We're helping us recruit into our studies. We're consenting our patients, and actually we're getting a huge, I've been overwhelmed by the patients' willingness to be included in research as well. These are sick patients. They are unwell. They're feeling miserable. They're struggling to breathe, and they are willing and able and actively want to be part of this research response to help not just them, but all of the other people that this is affecting. And it's really touching to see how big a difference that's been made. And I know that a lot of our research nurses have come from, so I work with infectious diseases research nurses, but there's lots of people who haven't signed up necessarily to be going into to work in an infection environment, but they've all kind of flexed beautifully and kind of are coming and working in these challenging environments with wearing lots of PPE, working with difficult to deal with patients. And finally, sort of it's a shout out to a lot of our data managers as well, and sort of handling the data input. And what we found is that actually a lot of these individuals are seeing the challenges of how these patients are deteriorating on paper, and actually the support that we can bring to them for what's happening, sort of that clinical context, but knowing that the work that they're doing, while challenging, even if they're not directly seeing patients, the effect of seeing those patient stories as that data comes through our data processors before it gets passed on to the central ISARIC teams is actually quite challenging. But as a team, everyone's the thing that keeps people motivating through it is the fact that we really are making differences to how we manage these patients and getting people out of hospital and our understanding of them all. So that's really just what I wanted in my 10 minutes of a bit of an update on the Stop COVID response, is just to give people a bit of context about where we are in the city. But now I am going to pass over to our more formal speakers for today. So first of all, I'm going to invite Callum to have a chat to give us an update on the ISARIC study. And there's so much going on with the ISARIC, I'm really not actually sure what part of it he's going to talk about, and because it's all so interesting. So I'll pass you over to Callum. So as many of you know, he's a paediatric respiratory physician based at Alderhay, who is the CI for the ISARIC protocol, which is the Coronavirus Clinical Characteristic Consortium. So thank you very much, and thank you, Callum.
Good afternoon, everybody, and thank you very much for this opportunity for us to blow the trumpet about what we're doing here in Liverpool, really to support the national research response to COVID. I'm leading up the ISARIC, which is the International Severe Acute Respiratory Infection Consortium, and in the UK, we've set up a particular study group looking at coronavirus and clinical characterization. The three lead organisations are University of Liverpool, University of Edinburgh, and the University of Imperial College London. And today we're going to talk about the major outputs that have come out most recently and which have had impact on policy decisions, particularly around schools and potential vaccination and risk factors. So that's the boring slide of conflicts of interest, which if anybody wants to see, they can read later on. There's 4 topics to cover today in quick succession, so I'm going to be pretty fast fire here. First of all,
sorry, Callum, sorry to interrupt. Your screen's not moving through your slides.
Right. So
screen share.
Is the screen share still not working? I will reset it, and bear with me, please, and we will reset that. It should be screen sharing. Here we go again. I'm still getting an error on my Are you seeing it now?
So we can see you're at slide 4. Do you want to move to slide 5 and just check that we're transitioning through them?
Okay. Can you see one that says introduce ISRIC 4C and the ISRIC WHO characterization protocol?
No, I'm afraid not.
Okay, right. We'll do it the old-fashioned way. I will stop that, and we will do a window share, which is crude. Okay, apologies, folk.
It's a wonderful world of Zoom technology. It affects us all.
Luckily, this didn't happen when I was presenting at the European Respiratory Society last week. Okay, so what we're going to do is I'm just changing the screen format, and we're going to do this the ugly way. Right, try this now, screen share. Okay, I'm hoping that you're now seeing a screen.
Yes, we are, thanks. And yes, and we can see you scrolling through.
Smashing, that's great. So the International Severe Acute Respiratory Consortium covers now 50 networks in 132 countries, and Britain is but one of that network. And our concept of operations was to have pre-written protocols so that we were ready to do research in advance of a pandemic. In the UK, this meant that we have recruited cases of MERS, that's the Middle East Respiratory Syndrome coronavirus, sometimes called camel flu. And we were able to recruit camel flu in 2013 and 2012. We also managed to recruit cases of monkeypox. We had 3 cases of monkeypox in the UK in 2018, and we managed cases of monkeypox and MERS, so monkeypox in Liverpool, which is quite something. We felt we were feeling quite smug about recruiting perhaps 1, 4, 8 cases at a time. We never imagined that we would currently be recruiting now. We've now got 81,000 cases, and it's really allowed us to provide some very useful information to the government. This graph shows you one of the earliest findings, which is the difference in case fatality rates between men and women, and it is really true that women are the stronger sex. They really have about a 10-year advantage over men for survival from COVID. The other important feature is that the risk of death in young people is incredibly low. If we start to look at the effective age, it's actually the risk, the magnitude risk is 10-fold greater if you're over 80. But even if you're over 50, you're talking about roughly a 3-fold risk compared to someone under the age of 50. So a lot of people think this is a disease simply of the frail and the elderly. Absolutely not. There's plenty of people of working age who have been killed by COVID. And tragically, we've now seen 650 of our colleagues in healthcare killed by COVID. When we started to look at ethnicity, we were able to identify that particularly people of a South Asian background were at a greater risk of death, roughly a 20% increased risk of death. Now, sure, it's not as big a risk as being old, but that size effect, a 20% increased size effect, is large and is more than we would expect to have seen with perhaps deprivation alone, raising issues that there may be either inherent genetic differences or underlying comorbidities that are different in this population. So we took this analysis further and did some complicated statistics using the bioinformatics team at Edinburgh University who specialize in this kind of work. And they identified that underlying diabetes in the South Asian population was contributing quite a large effect in this group. And that was quite an important finding. But they also found that even taking diabetes into account, 80% of the effect was unexplained. So some of that effect will be to do with deprivation. Some of it may be to do with genetics, but we also suspect that it's a dose effect because many people in the South Asian community have prominent roles in public sector and public facing, as it literally face-to-face roles. which may mean that they've been exposed to higher doses in the community because of these roles, and as such have had a higher mortality. And this information is fed into government and is directing changes in policy and funding for research in that area. We looked very carefully at children, and if there is a silver lining, it is to say that children appear to be at very low risk of severe infection. And this gave us quite a lot of confidence about putting children back into school, getting education going again, and that with work from Public Health England to show that there's relatively low transmission in school children gives us confidence that schools should be the last thing to close down. In fact, of the outbreaks that we've seen associated with schools, well over half have been associated with teacher-to-teacher transmission and teacher-to-pupil transmission. It's very rare to have a pupil-to-pupil or pupil-to-teacher transmission in schools. So this has been very good news. This work has been published in the British Medical Journal, which is a high-impact publication. We're delighted with this work. The last piece of work I really want to talk about is much more useful for those in the clinical environment. We've been trying to identify features which would help doctors and potentially staff that may not be as trained as doctors, potentially nurse practitioners or junior doctors who are unfamiliar with an environment of a medical A&E, giving them decision tools that will help them discharge patients with confidence, or perhaps make them stop and think before they discharge someone, that a patient perhaps needs more senior review and should have their care escalated. And these are called decision tools. It is not a triage tool. Triage is when you decide who should be sent home, who should go to higher care, and who should be left to die. This is not about triage. This is about decision aids to get the best targeted treatment at the most appropriate time. And we took the first 35,000 patients that were admitted between February and May and essentially put them into a computer program, an artificial intelligence computer program, and asked this artificial intelligence program to use all the data that we had and come up with an answer. And in parallel, we gave the data to human beings and asked them to do their best using traditional biostatistics. And the human beings came up with 8 variables that are commonly available at the front door. So age, sex, number of comorbidities, how fast someone is breathing, how much oxygen they've got in their fingertips, how conscious they are, urea, which is a blood test, commonly available, very quick to get, and C-reactive protein, again, a very common variable to get. So these 8 variables turned out to be very predictive of outcome. And we found that the artificial black box, the artificial intelligence machine, which took, I think it was 41 variables, could not beat the method that was designed here. When you do an analysis like this, you should never sit in your hands and feel confident that it's right. You need to repeat it using a further large data set that's entirely separate. And that's called a validation set. So we did the derivation, the design phase from February to May with 35,000 patients, and the validation from 21st of May to end of June, that's the end of the first wave, with 22,361 patients. And that's how we validated it. We did a further validation by cutting the country in half and doing a north-south comparison to check on the validity. And the model held true. And this is how the tool works. People really don't need an app. They don't need a computer. At best, they might need a pencil if they can't count up to 21. But Stacey assures me that yeah, you can do that. That's good. So you count up to 21. You take that count across, and if you've scored 20, for example, you go up the graph, come across, and you can identify that person as an 80% chance of dying based on these features. So that would be somebody that you want to escalate care to quite quickly. And if you got a score of, say, 5, you could be quite confident that this person's likelihood of death is very, very low. That's the kind of person that could be cared for potentially in the community with some safety net advice. This is the distribution of the score throughout the population that we studied. And that's the kind of shape you want to see. You want to see a nice balance of scores across the population. And this is this is how we do the validation. Is you take the observed probability, comparing it with the predicted probability, and you see how well the score performs. And the closer to that line, the happier we are. And then the other thing we do is we compare these scores with existing tools that are out there. And a very common one used is CURB-65, which is a pneumonia score. And the 4C score outperforms the CURB-65, which gave us satisfaction. So this is a very high impact publication. Again, it's gone to the Department of Health, it's been considered by them for use, and it's been published again in the British Medical Journal. So that's, it's quite unusual to have a research study that starts in February, collects patients up to July, and by, let's see, before the end of August, you've actually got 4 publications in high impact journals. That's really quite exceptional. And it shows the amazing dedication that the Liverpool research team, working in collaboration with Edinburgh and Imperial, has had to turning this data around. And this data has been shared at the highest level and is now influencing future policy. I need to mention that the money that comes in, we've got around about $4.5 million from the National Institute for Health and $5.5 million from the Medical Research Council, and plenty of integral support from core funding from the University of Liverpool as well, including actually one of the cancer charities, the Experimental Cancer Medicine Centre, which allows me to segue very neatly, I think, to Carlo, who's going to be our next speaker. So thank you very much.
So thank you very much, Callum. So that was very, very interesting. And as I say, as Callum's alluded to, this research really is being implemented into guidance in clinical practice as we speak, and it's making real changes. So as Callum says, we're now going to move over to Carlo Palmieri, who is one of the professors at the Clatterbridge Cancer Centre, who've recently moved next door to us at the Royal into their very nice new shiny building, and who's going to talk to us a little bit about the CCP cancer study, which is an add-on to Azaric. So welcome, Carlo, and the floor is yours. I think you might be muted.
So thank you, Stacey, and thanks, Callum, because this segues quite nicely. So I'm going to be talking about CCP UK and actually the sort of pre-gestation stage of CCP UK, because I'm going to be presenting some data of the cancer patients that we've pulled through. And actually, this is only the second time it's been presented. The first time was a few days ago at a virtual European meeting. So this is a second outing of some very fresh data. The largest global data set of cancer patients, and the first time cancer patients have been compared to non-cancer patients recruited prospectively in the same cohort. So very powerful data and some powerful messages. So just a brief intro. So I'm just going to briefly give a perspective of cancer in CCP UK, very, very brief. I'm going to present some of the data that we've recently presented and analysed, some of the unanswered questions in cancer patients which the data raises, and just an introduction to CCP UK. So as Callum's quite nicely laid out around the CCP UK protocol, Callum is the chief investigator, was activated on the 17th of January at the request of the chief medical officer, given the pandemic. As of the 17th of August, when we did this data snap for our presentation, there were 258 healthcare facilities with 78,603 patients, both paediatric and adult, on protocol. And Callum's referred to some of the key publications, and they're listed at the bottom there. Now, one of the key things about the ISRIC protocol and CCP UK is that it's a unified approach. If you walk through the door with cancer, cardiac disease, one leg, one arm, you get the same data collected. So you can be compared to other patients in that protocol. The data is very COVID rich. So there are key unified elements, key elements which are collected on everybody, which means we get the same data on every single patient, whatever their colour, medical background, previous history. So very powerful and done in real time. So the key data elements for cancer are these two forms initially. So comorbidities captures a number of key comorbidities as listed there. One of them is clearly cancer. So patients who walk through the door with a history of cancer any time get that box ticked. When it became clear that cancer was important and potentially cancer treatment was important, an amendment was done in April to collect patients on active treatment, either chemotherapy, targeted therapies, immunotherapy, antibody treatments, previous bone marrow or stem cell transplantation, patients with lung cancer had radical radiotherapy, as well as hematological disorders at any time point. What we lack at this time point, I'll come back to later, is details on the cancer and the treatment. So that is a weakness currently, but one we'll be addressing, and I'll come to that. So this is what the database is currently showing for cancer patients. So there are 78,603 on the database. Completed outcomes, patients who we know the outcome of, there are 66,594. Patients with cancer form essentially 10.5% of the total population. I'm not going to read out the numbers for brevity's sake, but they're laid out. 8% have a history of cancer, and as of when the amendment was made, 2.5% of the population have an active treatment, i.e. they ticked one of those boxes. So together they form 10.5% of the total population. And clearly, when I analyse those 66,500 cases, there are probably more in the other cases that have not yet completed outcomes. So we're probably looking at over 8,000 patients now with cancer on the database. So I'm just going to present some slides on the patients themselves. So age and sex. This is a slightly older population than one might expect with cancer. So the median age is 69.4 in no cancer, 77.8 with history of cancer, and 72 on active treatment. Males predominate. So as Callum says, the female sex is a stronger sex, and even with cancer, less of those are represented in those populations as listed. Just want to point out some things around the presentation to hospital, because I think this shows you the power of the data set. Now, you can see here the proportion of patients presenting with the key features: cough, fever, shortness of breath. They're the same in cancer patients and non-cancer patients, but what you'll notice is that the proportions are slightly different. So if you're on active treatment, most patients present with dyspnea, not with fever. The other thing to note is, and the size of the presentation make it different, if you look at bleeding, actually bleeding is much more common in the cancer patients than on active treatment. So the database can actually pick out subtle differences in the population. Again, shows you that the power of large data collected in the same way on the same forms. So very powerful. But in essence, there are no clinically significant differences between the cancer patients and non-cancer patients. So let's get to the meat, to some of the fresh data that we've acquired as a result of the data. So these are the patients I previously referred to with no cancer, history of cancer, and active treatment. If we look at the patients escalated to critical care, if you haven't got a history of cancer, 14.6% of the population get escalated to critical care. And by critical care, we mean level 2 and level 3, HDU and ITU. If you've got a history of cancer, 7.6% were escalated, as compared to 9.5% on active treatment. So there are numerically, and I'll come to the adjusted analysis, less patients escalated to critical care with cancer. If you look at patients ventilated, 8.9% versus 4.1 versus 4% with those with a history of cancer on active treatment. So less patients with a history of cancer on active treatment are ventilated numerically. And then if we look at deaths, numerically more cancer patients die with COVID than non-cancer patients. So the mortality in the non-cancer cohort was 29.5% for completed outcomes, 44.3% with a history, and 42.3% on active treatment. These are unadjusted analyses, and I'll come to some adjusted analyses in due course. So clearly patients with cancer, less likely to be escalated, less likely to be ventilated, more likely to die on an unadjusted analysis. Now, if we do an adjusted analysis for age, sex, and those comorbidities, you'll see that patients with cancer or on active treatment are statistically significantly less likely to enter critical care, with odds ratio of 0.65 and 0.56, statistically significant, and they almost mirror some of the chronic diseases. So let's turn to mechanical ventilation. So when we do a multivariable analysis, as we did before, if you're on active treatment, you're significantly less likely to be ventilated at an odds ratio of 0.52, p-value of 0.001. History of cancer drops out as not being significant. Again, similar to somebody with chronic pulmonary disease, if you compare the on-active treatments. So let's look at survival. So this is an unadjusted hazard ratio of 1.62 for cancer patients. So they have a increased risk of death, significantly elevated. The 30-day mortality, as you can see, the mortality really plateaus by 30 days. There are not that many deaths after 30 days. By 30 days, 40.5% of cancer patients are dead, as compared to 28.5% with no history of cancer. So if we dig a little deeper with regard to age, then we can see some interesting things. So this is the first time that this kind of data has been seen for different age groups, cancer versus known cancer. Now, what you can see is that your chance of dying with COVID are clearly age-related. It goes up with age if you have cancer or don't have cancer. Now, what you'll notice is that the hazard ratio, the risk of dying, is actually the highest if you're young and have cancer. So while your absolute risk of dying is smaller than if you're less than over 80, the actual risk is higher the younger you are. And as Callum referred to, if you're a woman or if you're a man, if you're a woman, you seem to have 10 years less of mortality. Here, it appears that cancer adds 10 years to life, and you have the mortality of somebody who's 10 years older. So clearly, the effects of cancer on death as you age dissipate, still has an effect, but dissipate. So there's clearly the effect is bigger the younger you are, and it's the absolute difference between these groups between 4% and 13%, and the hazard ratios are listed. And these are unadjusted analyses. So if we then turn to an adjusted analysis, and this is the last data slide, you'll see that if we baseline against somebody who's less than 50, firstly, age remains the strongest predictor. If we then look at patients less than 50 compared to somebody who's more than 50, adjusted for these factors down here, I won't read them out for brevity. Essentially, if you're less than 50 with cancer, you're about 3.5 to 5-fold more likely to die. If you then look at the older populations, while the hazard ratio is clearly much higher than somebody less than 50, the difference between the groups is much less as when you look at those hazard ratios. So we're seeing clear age effect. This is the first time this has been observed in any of the series. All the previous published series, which have been sort of cross-sectional multi-institute analysis done by oncologists, have all said age is a major risk factor. But what they've missed, because they've not had the non-cancer population, is actually the risk is greater in those younger patients, while smaller is bigger. So this leads to a number of unanswered questions. Firstly, why are patients not being escalated to critical care or mechanical ventilation with a history of cancer? We don't know. Many hypotheses, but we actually don't know. Why are younger patients having a higher risk of death to non-cancer patients? Do the mortality vary by tumour and stage? Do different modalities influence outcomes? Does the clinical features and severity of COVID vary by type of tumour and treatment? Are there any clinical laboratory variables that correlate with COVID mortality and severity? And more importantly, when we control for all the patient-rated factors, age, ethnicity, and other things, how do the cancer outcomes compare to the matched non-cancer cohort? Because we can do that with the data set. So this brings us then to CCP Cancer UK, which is the companion study to the ISRIC CCP UK, because we're using the cancer patient. So firstly, this is a multidisciplinary project. To date, all the cancer projects have been card-carrying oncologists collecting data, mainly on the cancer episode around outcomes. But this encompasses infectious diseases, oncologists, anaesthetists, surgeons. This is co-developed. Lance Turtle is my sort of ID wingman for this project. So it's joint developed and led. So this really is a co-developed, co-led project, bringing together the key important specialities. It is open to all centres of Open CCP UK. We're going to do a real deep dive into those 7,000 patients to get data on tumour type, treatment, timing, and longer term outcome data. Because of the power of this data set, we can do a matched cohort study to really understand what are the risk factors in the cancer patients that are leading to mortality, try to understand some of those things around the escalation of care. Clearly, I've not really referred to, but the protocol collects biological samples, clearly very rich for translational research. Ultimately, this is about informing policymaker decision around shielding and nature of care, enabling oncologists and ID physicians to make robust, evidence-based clinical decisions around the patients in front of them. But perhaps more importantly is enabling our patients and their families to make informed choices around their treatment and their societal interactions. At the moment, our patients get a letter from the government saying, stay at home. It doesn't say stay at home, your risk factors if you get COVID are X, Y, or, you know, so we have one size fits all for the way we look after our patients or trying to reduce their risk. We need to be much more tailored, more nuanced. And that brings me to the acknowledgement slides. I'm not going to read through this, but just to acknowledge the CCP Cancer UK group, LHP, who've helped bring people together, Dan Palmer, who's my colleague at CCC, who's the director of the ECMC, who's helped provide support, the funding agency for CCP Cancer, and actually Clashbridge Cancer Centre Charity, who provided the sort of seed corn money to get us up and running before we got the large grant to fund this project. Thank you very much. Hope I was on time.
Thank you very much, Carlo. That was really interesting and nice to see the evolution from sort of the more generic ISARIC protocol and really going into the specifics for cancer patients and thinking about how that much more powerful disease set, sort of data set, can be used by different specialties and the sort of the benefit of interdisciplinary working. So I'm going to move quickly on to Mark and Pippa to have a chat about sort of COVID and the social science response. So just to remind everyone that the Q&A box is open, so if anyone's got any burning questions from Carlo and Callum's talk, and as we go through Mark's, please just pop them in there and we'll hopefully have some time for some questions after this. Thanks very much. So over to you, Mark.
Thank you, Stacey. Can you see the slides on screen?
We can, yes.
Yeah, that's great. So yes, I'll say a few words and then Pippa, I think, is going to come in with her project too. We obviously are here representing social science today. We wish to emphasise, I suppose, underlying the importance of a team science approach, humanities, social science, science, medical expertise in addressing what is a COVID is a medical, but it's also a sociological and economic and geographical, and political, cultural problem also. So we're, I suppose, interested in a wide range of social determinants of the impact of COVID-19 on some of the aftershocks, the economic aftershocks of COVID-19 in my own particular project, and also, I suppose, the Build Back Better campaign, how we're going to rebuild the Liverpool economy again, and the extent to which we can remediate some of the underlying drivers of health inequalities, particularly around inclusive growth and inclusive development. So my particular project in the context of this wider exploration of the social context and political and economic context of COVID and its complex entanglements with the public health policies and public health outcomes is really around the economic impact. The project, which is one of 6 or 7 projects that have been funded through the Liverpool COVID Fund, is looking at the Liverpool economy. Of course, we know that we are amidst a recession. This is a very peculiar recession. Between 1870 and 2021, there have been 14 global recessions of consequence. This, in terms of the trough, is expected to result in a shrinkage of the economy, probably the 4th worst of those 14, the worst since the Second World War, which is quite something considering the 1970s oil crisis and the global financial crash of 2007, 2008. So the dip is expected to be larger. The economy is expected to shrink globally by 6%, according to World Bank data. The British economy is expected to shrink by 10% in the context of 2020. So it's very deep and very significant economic ramifications that COVID is leading us to. Of course, it's a different kind of recession because the structural underpinnings of the economy were reasonably strong, and so there is hope that it's a V-shaped recession as opposed to a tick-shaped recession, or even worse, a U-shaped recession. We hope to bounce back 2021. But of course, all that depends on the successful search for a vaccine and its implementation. And also for us, it depends upon a resolution to the Brexit crisis, which is a double whammy in the context of the economic impact of COVID. So very much the outcome of this, whether it's V-shaped or not, will depend upon a number of factors. And if those factors are not positive or heading in the right direction, then we might be in for a very significant and longer term recession, which clearly has huge health implications and are already deprived Liverpool city region. The graph to the right shows the number of countries in recession, and we see that what is also marking this out as being unique is the sheer number of countries around the world that will tip into recession, which is negative growth rates for 2 quarters. And this indicates just the extent to which this is a global recession, and in this entangled globalized economy, particularly given our port city function, that clearly is going to have significant impact. Even if we pull out of recession, if other places don't, that's going to have significant impacts on us. Britain, as I said, throughout 2020 is expected to shrink in its GVA, its gross value added, the output, national output, by 10%. Northwest slightly less, and it will vary within the Liverpool city region. This is GVA changes 2019, 2021. Interestingly, Liverpool is expected to shrink in terms of the city itself by less than the national average, so a whopping 7.3 decline in an already suffering economy. But it's expected, subject to a vaccine being available or signed off by January, if not clearly not implemented by January, but these are KPMG figures, assuming early 2021 vaccine and also a successful negotiation of the Brexit trade deal. And there'll be bounce backs clearly in 2021, which will hopefully make this a recession which is short, sharp, deep, but also short-lived. But other places, particularly Knowsley, is performing well above the national average, and that's related to aerospace industries and the fact that those industries have been impacted by the decline in travel. So we're expecting deep, but possibly not as significant economic contractions in Liverpool as one might expect, given the fragility of the labour market, the history of deindustrialisation, the poverty of the city region. What I do want to say, though, just before rounding up, is that this, of course, is contingent on a whole number of national public policy, and whether Liverpool can continue to sustain itself is very much dependent on the ongoing outcomes of the furlough discussions. Liverpool has had 60,100 people furloughed. 29% of all people who are eligible for furlough have chosen the furlough route, or their employers have chosen the furlough route. 14,200 self-employed people have been kept going by the self-employment income support scheme. Therefore, 75,000 residents in Liverpool are currently employed on the basis of critical government supports have negotiated since March through this period. And there's obviously huge concern that in October, the Chancellor's announcements notwithstanding yesterday, that there's an increased precarity, and if those 75,000 find that the Chancellor's scheme really doesn't provide the safety net they need, then we're going to have some trouble. Last slide before handing over to Pippa. We have tried to support the city region in understanding the economic impacts through policy briefs. We've published 25 of these, so it's accumulating to be a body of work that we hope is going to contribute significantly to the, I suppose, the civic agenda and civic contribution of the university at this particular time, covering all sorts of areas: economic, social impacts, and building back better. We have launched a reopening monitor, where we're trying to track how the economy is reopening after lockdown and what's working, what's not, comparing that to 9 other British cities. And finally, we are feeding into the Liverpool City Region recovery plan, and we're trying to imagine what a Build Back Better really does mean, so that we can address some of these multiple deprivation issues that go to the heart of the health inequalities that the city region suffers. Pippa, my apologies, I'll hand over to you.
Thanks, Mark. I'm coming up now, and I just need to share my screen with the slides. Thanks very much for that. So lovely, thank you. Let's see if I can put mine up as well. Are mine up there now? Can you see those yet?
Not yet, Pippa.
Okay. Let's try again. Is there a quicker way of doing this?
That's it come up now.
Thank you so much. Thank you. Thanks so much, Mark. So I'm here as well to share some of the social sciences input that's going in terms of the COVID work in the university, and I'm part of an Area C grouping which has myself, has Liz Perkins and Bridget Young and Kira Kierans, and we have different projects that we're involved in, and I'd just like to share a few moments, conscious of the time, to give an example of some of the activity that's going on. And I am going to talk about this Let's Keep Talking project that we've got underway. I'm based in the management school, and we have been working for at least 5 years looking at some service research, looking at what makes a service effective and what do we mean by effective and effective for whom. And so we've been looking at a number of examples of healthcare services and trying to work out from the patients, from the carers, from the professional perspectives, what makes a service effective. The team ourselves, I don't seem to be able to move through the slides. Sorry about this, Stacey. Marvellous, thank you. So the backdrop to our research is very much that service research. So we're non-clinicians, but we're coming at it from a point of view of trying to look and see what each different stakeholder actually needs. The service under review falls within the sort of mental health service area, and we know, next slide if that's possible, we know, I won't re-rehearse the whole conversation in terms of mental health indicators because we're very familiar with them, but we went into COVID knowing and having researched a number of these areas already, that we have as a set of circumstances which affect many within society today. Of course, Mark's overview he's just provided in terms of the economy very much feeds into that agenda, and the inequalities within healthcare unfortunately have become quite profound in many respects, particularly we find it within our local region. Now, if we could go on to the next slide, thanks. Marvellous, thank you. So when we went into the lockdown situation, working with one of our collaborators, Steve Flatt, the Psychological Therapies Unit here in Liverpool, that particular unit shifted online and started to offer a Let's Keep Talking service to try and reach out to a population who actually might have no access or limited access to other services at that particular time. So it was launched March 2020, entirely run by volunteers who were trained by the unit themselves. And since that time, they've taken 700 phone calls, roughly between 5 and 60 minutes a day, averaging about 30 minutes. With 100 individuals, so multiple phone calls basically with some people and the theme has been very much seeking support and linked to COVID, linked to the lockdown, but also linked to other factors as well, which were pre-existing before COVID and were exacerbated, as one might imagine, by that. The initial work looking at if you like, the effectiveness of the service has found that 74% of service users have rated the service extremely useful. Now, as a social scientist, we want to know what that means. It's more than numbers. We want to understand the stories behind it, and that's where the project is now moving into the next phase. We've got the initial statistics, but we're now starting to find those stories out. So if we can go on to the next slide, and we're doing that through a strategy where we are now interviewing, having conversations. I don't want to use the word interviews, having conversations with the clients who are involved in the service, who've taken up the service, to find out why. We're going to interview the volunteers involved in it and also the referrers who've referred to the service itself. And there are some striking themes that are starting to emerge, just sort of highlighted here. There is a predominance of people who are more elderly, who are living alone, who are experiencing feelings of isolation and loneliness, and they're needing a conversation. And very much coming through has been, it's not necessarily, they would not necessarily have been utilising services pre-COVID, but ended up in a situation of being quite isolated from their community. So the client feedback is an example there. In terms of volunteers, if we can go on to the next slide, what makes the volunteers, what are their experiences of this? They're talking about the types of people so far that they've been speaking to. Again, lady in her elderly, isolated, dealing with an illness, getting very lonely. Interesting though, in terms of the intervention that's being used by this particular service is solution focused practice, and they are seeing very much the moving forward with people in terms of sense of humour, trying to move towards getting people back into some way of seeing beyond COVID and trying to, if you like, utilise their own resources to somehow traverse these quite difficult times. And the referrer, onto the next slide, why is anyone referring to people into the service for anxiety, panic attacks, low mood, isolation? But also because it's quite a unique service in that it tends to be able, because of the nature of the setup, to keep talking with people on multiple occasions as they determine through the weeks, through the months, rather than the traditional quite sort of standard protocols that people have to go through to access a service, which can provide many barriers. We are onto the final slide. That was very much a shuttle-stop tour, but we're very much now into the phase where we are collecting more data, more of the stories, to find out what is it actually that's making this service effective, why are people turning to it, so that we can look into the other data in terms of what we have in terms of inequalities to determine who is using this service, and are we adding to inequalities, are we exacerbating, or are we actually helping by reaching out to people who otherwise we might not have reached through other services. So there's quite a lot of questions going on for us at the moment. Thank you.
Thank you very much, Pippa and Mark. So I think that was a really lovely kind of introduction to the broader context of COVID. Certainly as a kind of hospital-based doctor, we tend to look very much through the kind of health lens, so how it's affecting patients with their physical illness. But clearly, as we all realise that this isn't something that's going away necessarily anytime soon, that the need to understand it in its broader societal context becomes ever more important, as this is something that's affecting us all, whether we're infected with COVID, but the impact is felt broadly and widely. So we only have a few minutes left, but I'm very happy to take questions from the audience if there's anyone who's got anything burning, sort of any burning desire to chat about anything, or if there's any questions, I guess, between our panelists, if there's anything that sort of Callum and Carlo or Mark and Pippa would like to ask each other. Mark?
Yeah, I would just like to very briefly pitch in, just like you're saying there, Stacey, you know, this nexus between the social science, humanities, is something which causes us in the social science, in some respects, some anxiety around, because we feel obviously COVID in many ways is a social and political production. It's not just an epidemiological production. You just can't separate out virus from social processes. And I think sometimes we feel, I guess, within the medical profession, and Callum and Carlo are exempt completely from this point, but there's a sense that maybe it's a supplementary or it's an additional layer of it. I think the team science never been more important. This is a challenge you're just not going to solve unless we collaborate as an interdisciplinary team. I also want to say that public health in the early 20th century, as Callum would know from other contexts, the relationship between urban planning, urban development, urban regeneration and public health was very tight. in the Victorian period up until and then somehow it's got lost in the period after the Second World War. But I think one of the outcomes of this is that public health and urban planning are going to come together again in ways that the design of cities is now much more than simply design for economic reasons, or we see all sorts of changes to the city with the 2 meter urban planning. There's a whole tradition now, especially how do you plan a city to function on a 2 meter basis. So I really think the conversation in part that I'd like to see is about reactivating a very tight relationship between cities, public health, and their governance that was there that we've lost, and now we need to come, I think, get back to.
I can see Carlo nodding. Do you have any specific comments or you'd like to come in on, Carlo?
No, I just want to agree that with Mark, that obviously, going back to the Victorian time, slum clearance, the effect on health. So I think health and social design, even just as we design our hospitals, we're trying to be much more holistic, and art and an environment that is not clinical or very sterile. So I think when you go to cities, open spaces, be able to walk, fresh air. So I think COVID and sort of may lead to, as Mark said, a complete redesign, and thinking about how, I think I read an article about how do you design a city where you're 20 minutes from a hospital, workplace, school. So I think it is going to be to some, maybe how quick that happens, I don't know, but it's clearly economics impacts on health. That's important.
I've got 2 observations. It's actually what attracted me to virology 30 years ago was how something that I couldn't see could change society and change human behavior, and also how human behavior interacted with that virus. There was something fascinating about it. And the other observation is that when I tried to set up a study in Sierra Leone, if you didn't understand the macroeconomics of how money moves through society and the value of banking systems and security of money, you really couldn't manage a pandemic. And that was a critically important factor to how they managed to get the pandemic going. And the solution, which was quite bizarre, was to use some voting registration machines, which had never been used for voting, but they had in them biometric identifiers. And they were able to set up these voting machines to allow the healthcare workers to essentially identify themselves and then get paid. Because for the first part of the Ebola outbreak, the healthcare workers didn't get paid. And understanding what payment was, and that money was more valuable, because payment was actually 50% rice and 50% payment in some hospitals. So there you are. That's unless we've got a good relationship with our bankers and our financial understanding, you can't manage an outbreak. And that's what we're seeing now. The furlough scheme was absolutely critical to maintaining civil order, in my view. I think if we can't maintain civil order in the next winter, we're going to see some terrible things happen across our countries. If you think Black Friday is bad in Liverpool, imagine what's going to happen when people start running out of money. Thanks very much, folks. I really enjoyed talking.
Thank you, everyone. I'd just like to thank all of if there are any other comments, I guess, Mark or Pippa, before we finish for today.
If I could just, I would like to direct people to the policy brief series. The Heseltine Institute, is there for the whole of the university, but also for the Liverpool Health Partnerships as a city-facing public policy research institute. And anybody wants to contribute a paper, we've got some very straight-up medical papers, as well as some sociological, urban planning, economic papers. We're very interested in publishing them. They are high impact. They're reaching 3,000 people. They're feeding into the Build Back Better plan of the city regions. So they're available from the Heseltine Institute website. They're short, sharp public policy briefs. They're not 3,000 words. Those people who are used to publishing BMJ, you guys are knocking stuff out of. We'll find a very light translation into policy brief. We very much welcome some contributions through that, and I would direct people to look at them. I think they're a useful resource.
That's lovely. What we'll do is we'll make sure that the link can be available sort of through the Stop COVID webinar website as kind of useful resources. So I'd just like to thank everyone for their time and for taking part in, as I say, in this 4th Stop COVID webinar. I've certainly found it very interesting. I think we've moved through from our very broad some of the broadest understanding of COVID as it pertains to the health system, through cancer, and then thinking about this as you say, that team science approach, and thinking about how it's affecting us all in its entirety, and that this isn't a solution that's going to come with from a single biomedical lens. It's that all of us working together and working in that interdisciplinary manner. I would certainly say that is, if there are any positives to come from COVID times, I would say my biggest joy has been working across teams and with different teams and different professionals, and that's been a real pleasure through this, if there can be anything that's positive to come from the COVID. But I would just like to thank everyone for their time and for their interest. And there will be another one. I'm not sure of the date of the next COVID webinar, but you are all very welcome to join. And thanks for your time. Bye-bye.
Thank you, Stacey. Thank you.
Bye.